We should first hear from Bernadette Jones, and then we can have our panel. So I'm not sure how we navigate between both of you. I think put Ms. Jones up so that she can start her presentation before lunch, so she's not left hanging in suspense. Tēnā koe, Ms. Jones, can you see me all right or hear me?
Kia ora. Yes, I can.
Can you confirm for the record, please, that your name is Bernadette Jones and that you're a senior kaupapa Māori researcher at the University of Otago, Wellington?
I can confirm that.
Thank you. Well, I would invite you to deliver your presentation to the tribunal.
Kia ora.
We have, just for your information, we have about 10 minutes before lunch, so we're not expecting you to finish it before lunch.
Okay.
And we have a PowerPoint, I understand. Which,
I will just share it with you now.
so this is Tribunal H18G.
Are you able to see my presentation?
Aye.
Tēnā koutou katoa. Ko kurohapo te waka, ko ruapehu te manga, ko whangahu te awa, ko kuangaroa te marae, ko ngā ware ki nā te apa te iwi, ko marae huatau te tūpuna, ko tangata paikaha Māori aho, ko Bernadette Jones aho. I present this evidence based on my identities, my lived experience as tangata paikaha Māori, as a senior kaupapa Māori researcher and nurse with expertise in hauora Māori, and my most important role as a nana of my mokopuna, who are our future. I've been a registered nurse in New Zealand and Australia, worked for over 50 years of nursing in a wide range of nursing areas, from paediatric, intensive care, community health and education. And more recently, for the last just over 20 years, I've been working as a researcher and currently a senior research fellow at the Department of Medicine, the University of Otago, Wellington. I'm a member of several health and disability committees. I will have membership with community networks and co-chair a regional disability advisory group, which did advise the previous sub-regional DHBs through Capital Coast, Hutt Valley and Wairarapa. More recently, I've been called on as a consultant to provide advisory support to Te Aka Whaiora and Whaikaha, the Ministry of Disabled People, around the impacts of disability, chronic health conditions, and achieving equity for Māori. My evidence covers three main points: an overview of our current research project, Te Ao Marama, Disability Perspectives of Tangata Whaikaha Māori, including context and rationale for why that research is needed. I want to give a snapshot of some lived experiences of tangata Whaikaha Māori who are seeking to ensure effective policy design and implementation by, with and for tangata Whaikaha Māori. And thirdly, identify what needs to change to ensure the rights of tangata Whaikaha Māori are upheld across all health and disability sector activity and equitable outcomes are achieved within these systems. And just to clarify, I use the term tangata Whaikaha Māori to describe Māori with lived experience of disability, and their experience of disability is defined by themselves, not defined by the medical terms, the impairments that is used. And it includes a wide range, and I really want to acknowledge terms such as whānau hoa, tangata turi, kāpō Māori, and the wide range of terminology that is used. And this is the umbrella term that I use for this presentation. The Te Ao Marama research project that I'm co-leading with Dr. Ingham is funded by the Health Research Council of New Zealand, administered via Otago University, Wellington. It was developed and designed in response to extensive gaps in Māori disability research and critical gaps in disability data for Māori in Aotearoa. The purpose was to understand perspectives of tangata whaikaha Māori, to develop culturally appropriate approaches to measuring and quantifying the prevalence of disability among Māori, and to quantify health, social and economic impacts of disability for Māori and translate our findings into policy recommendations. We've heard from Dr. Ingham about the current system of collecting data, and even in the last few weeks, the way that data is being collected for tangata whaikaha Māori in our census. There's been decades of underinvestment in research that is by and for tangata whaikaha Māori. There is no ring-fenced funding for Māori disability research, meaning we are left competing for contestable funding along with all other researchers. And this takes me back a couple of decades to before our really strong Māori researchers were advocating within the Health Research Council for some ring-fenced funding for Māori research. And I guess that's been an inspiration for me to take the lessons learned from our senior Māori researchers over the decades and take those lessons and put it into trying to improve things for tangata whaikaha Māori research. We've had a history of racist, biomedical, ableist research paradigms in Aotearoa that have excluded tangata whaikaha Māori, meaning there are few tangata whaikaha Māori researchers in Aotearoa, especially those using qualitative research, and that includes Māori methodologies like pūrākau Māori, Māori storytelling, which has been really undervalued by funders. It's not seen as robust and equivalent to quantitative research. There have been little or no direct efforts from funders to support capacity and capability of tangata whaikaha Māori as researchers in our own rights, leaving many of us to struggle in unsupportive environments, negatively affected by racism and ableism, etc. And I refer to page 411 of the NHC bundle, Decolonising Disability, a book chapter that a handful of tangata whaikaha Māori researchers got together, funded themselves to write. One of the quotes from that said, "Institutional racism was the basis for most of the research that I was involved with. It was essentially racist in its design and non-inclusive of Indigenous disability perspectives. It's only in recent years and with increased willingness from non-Māori colleagues that some of those racist approaches and biases have been slowly recognised and replaced." And I also want to acknowledge particularly Dr. Rachel Brown, who was for many years at the Health Research Council and was one of the few supporters of tangata whaikaha Māori researchers at the time. She was a lone supporter and she tried her best to encourage us to keep applying for research. And the support through the Rangahau Hauora section of the Health Research Council, but it was very difficult for them without the support of the whole council. I'm not sure whether, Ms. Faint, whether you want me to continue or is it time to take a break?
I think that might be a good place to stop for lunch.
Judge Stone speaking. Yes, good idea. Thank you for being live to our...
Thank you.
I'll hand the rāko back to you.
Kia ora, and I'll just share my screen. So my next slide talks about the lack of data, and we've heard something about the lack of data, particularly this week, from tangata ture and the importance of data for them. And Dr. Ingham has also talked about and referred to the lack of data. I just want to emphasise, mostly when we talk about disability, we are using colonial concepts that are in themselves disabling. How tangata whaikaha Māori choose to identify ourselves is not part of the current system. Even if the terms do not make sense for tangata whaikaha Māori, not using them or being forced to identify as disabled results in barriers to accessing funding and services. And we have heard of an absolutely prime example today from Dr. Brown, a very articulate, educated health professional who herself was forced to use a term disabled, which is often whakama for us. It tramples on our mana. She was forced to use this term, otherwise she could not access some services that were needed for her tamariki. The example that I also wanted to give you, and I'm really here to try and facilitate the voices of the participants through the research, but I will give you this example from my own experience in the health system. And I've already said I've done this for over 50 years. I trained at Wellington Hospital. I know the system really well. I've been part of trying to improve it, and I've been an advocate for patients and communities for a long time. I acquired my disability when I was working in Australia, when I was working as a nurse. We didn't have the equipment to prevent injuries like spinal injuries then when we worked in intensive care. As 17-year-olds, we lifted unconscious, very large, heavy patients, and mostly young females. You were lucky to get one person who could help you. Years of doing this resulted in a permanent spinal injury for myself. I didn't see myself as disabled. I found ways around it. When I moved back to New Zealand, I changed my career, retrained as a researcher because I could no longer work in intensive care. There was no supports for a disabled nurse for me to continue. After many years, and with the support of my husband, he said, you need to get disability support. You need disability support, but I could not get that if I didn't label myself disabled. I felt I was a fraud by using that term. I was forced to use it in the current system. It trampled on my mana. So I mihi to Dr. Brown for her words today. I feel her mamai. This is representative of many, many others in our community that's going on right now. It took me several years to try and even get an assessment through the primary healthcare system that we have today. If you ask my whānau, they'll tell you, I can be really stroppy. I'm not shy. Our Jones whānau, not scared to speak out. I'm trained in this health system, but I couldn't get the support I needed. I couldn't get an assessment. What happens to our whānau, tangata whaikaha, whānau out there who aren't as articulate, who aren't trained health professionals, who are too whakamā to speak out, who don't think they deserve the supports that are there. They don't even know that the supports are there. They don't know how to engage in the system. Currently, you have to go, or one of the ways of getting assessed is going to your GP or a doctor who is mostly, I would say, untrained in disability. They've got to confirm your eligibility for support services. In my own experience, this is often very poorly done and the referrals incomplete, resulting in being assessed as not eligible. It took me, advocating for others and myself, many years to fight the system and get reviews of these systems to try and get disability supports when you're eligible. So yes, the current tools that we're using, the questions that are used in data collection are not academically robust or culturally validated. And as Dr. Ingham said, they don't incorporate Mātauranga Māori concepts for tangata whaikaha Māori. We don't get a chance to even see our assessment and have input into the assessment. It wasn't until I followed up and rang a nurse and said, can you tell me what's on the form, what got submitted for the assessment and where it went wrong. And I realised that they hadn't put anything about my disability in there because they didn't know, they didn't even recognise it. We don't have training in our medical schools. There's very little training about disability, particularly tangata whaikaha disability. What the current tools for measuring are called the Washington Group short set for measuring disability. And this is from the global north, and it's a very medicalised measure. It measures significant functional limitations, and it's used as a proxy for disability. They've not been validated for Māori or other Indigenous people. So you've probably seen this before. It's come out in a census. There's a long version and there's a short version. So you've got to self-identify as, for example, vision impaired. I have no difficulty, some difficulty, a lot, or cannot do it at all. And when I've supported tangata whaikaha Māori in looking at these assessments, I can tell you that the majority of them will put no difficulty or some difficulty. They don't want to complain. They've been told they complain within the system. They don't want to be seen as complainers. They see people far worse off than them, and they don't want to take services or money that they think others might need more. They want others to benefit. So this is not being explained to them properly. They don't understand that if you do not answer this correctly, this can have a huge impact on whether you get services or not. I just want to read you out a quote from one of our participants in our study. My thought is that having a disability doesn't define who I am. From a Western worldview, they try and categorise us. They put us in that one box and go, you're disabled. But from Te Ao Māori perspective, it's who we are, and we walk with that journey. And we continue to embrace our Te Ao Māori. A snapshot of our qualitative findings so far will show you these constructs of disability and related terms fail to align with Te Ao Māori, who have multiple identities and perspectives. It demonstrates that tangata whaikaha Māori experience an equitable access to the determinants of health and well-being, an equitable access to services, and differential quality of health and disability care. And you might recognise that this comes from a world leader in racism, Dr. Kamara Jones, who worked here in Aotearoa some years ago and worked with the Ministry of Health. This is how the discrimination develops, this is how it is, and how it continues. And this is the state of disability care for tangata whaikaha right now in Aotearoa. Our participants experience racism, ableism, and disableism, compounded by the intersection of such types of discrimination. The solutions they suggest include re-indigenising the health and disability systems, providing holistic wellbeing services, including tangata whaikaha Māori and decision-making structures with equal partnership rights, designing and implementing services for tangata whaikaha Māori. We do not want to be left out of that design. The second part of the Te Ao Marama research project is a quantitative survey, and the findings should be ready about June of this year. We needed to go in and with tangata whaikaha Māori, make an attempt to develop some culturally appropriate approaches to measure disability from a Māori perspective. We administered a nationwide survey using kaupapa Māori epidemiological methods to quantify prevalence amongst Māori and the health, social and economic impacts of disability for Māori in Aotearoa. Survey closed at the end of last year. We got over 7,000 Māori participant responses, and analysis is currently underway. I just want to flag that while 7,000 might not seem like a lot, surveys of this type are lucky sometimes to get 3 or 4%. So, you know, we were close to about 10% in a pandemic, in the middle of natural disasters, cyclones, floods, etc. We're often told that Māori don't want to take part in research, but I would venture to say that if you design it the right way and you have the right people doing it, Māori are really interested in this, but they just need to be able to trust the process. It needs to be led and designed by them. My second point comes to tangata whaikaha Māori experiences of seeking changes to structures, policy and practice. One of our participants said, we aren't given a voice. For years and years, we haven't had a voice, really, hence why I think the health system is, I think it is just fully derailed. I want to give you an example in the last 3 years of how this is playing out in our health system. I was seconded to the Ministry of Health along with a small team of disability experts led by Dr. Ingham during the early stages of the COVID-19 pandemic in 2020. And this was, I would say, through a very committed health official, James Poskett, who was in DSS at the time, who saw it as his commitment and his response to Te Tiriti or Waitangi, because there was virtually no response in there that we could see. We had difficulties being heard within that ministry. Not talking about individuals, there were some very committed and very hardworking individuals. But as tangata whaikaha Māori, even when we were within that government machine, it was really difficult. In response to serious concerns about complicated public health messages, we developed Dr. Ingham's COVID-19 bubble concept, took it from a concept, built and designed for the most vulnerable and the most at risk, for Māori populations, for elderly, for children, for whānau, for disabled. We tried to get it approved through the machinery, the rigid, lengthy internal communication process within the Ministry of Health, and we couldn't get it through. We tried to get it to Dr. Ashley Bloomfield and said, this is how you need to explain it. Not a medical model, using this disability lens, tangata whaikaha Māori, this will help everybody to understand it. It was only picked up by chance. I saw an opportunity to get the concept directly to the Prime Minister via a communications advisor. And we were really heartened to see the Prime Minister bring this to the attention of the public. And I guess the rest is history. You know how we used it in Aotearoa. You know how it was picked up by family, whānau, We would walk down the streets and hear parents tell their children, quick, bubble formation, and in came the children when someone was walking past. We could hear elderly people who were designing their own bubbles, who could come into their bubble to support them. It wasn't a medical model. It was a really user-friendly model designed by tangata pai kaha Māori. We have experts out there. It's very difficult to get listened to. There was a huge lack of planning and prioritisation of tangata pai kaha Māori, and NHC were leaders, along with other Māori health providers during this time, trying to highlight just the position of Māori in general overall, and how Māori providers stepped up, because without that there would have been a lot more deaths. And this has been highlighted in the Tribunal's Hau Māori report. But still such approaches continued in the Omicron response during 2022 that were negatively impacting on tangata pai kaha Māori. I want to give you an example of a letter that came out that caused immense distress amongst the disability community in tangata pai kaha Māori, leading to no confidence in providers to act in our best interest, with the expectation, this is 2 years on, that whānau and friends will be our safety net, when many of us already rely heavily on this support, and for some that's the only support they ever get. This letter basically, in summary, came out from Ministry of Health, all district health boards and ACC, alerting disabled people in tangata pai kaha Māori that there's likely to be an increase in COVID cases and staff shortages. So you need to plan for this. We're going to temporarily cut some of the services. Whānau and friends will have to step in and provide you with housework, meal preparation, cooking, personal cares. We were alerted to this as researchers from a very distressed community where health and disability providers had unilaterally come to this decision to cut home-based disability support. Now, this is their level of understanding. They thought it's easy to cut household cleaning. That doesn't, that can go on the back burner for a few weeks, right? A few months, few weeks. But they don't understand. Somebody in a wheelchair, somebody who's incontinent, and you only need to speak to parents who have children who manage this all day long and during the night. It's not a nice to have. It's not we get a cleaner in once every week or once every fortnight. When whānau members are incontinent, this is a hygiene matter. This is a health and safety matter. But that wasn't understood and that wasn't taken into consideration. There was no purposeful engagement with tangata pai kaha Māori, whānau or expert tangata pai kaha Māori groups before this message was sent out. We had no opportunity to alert our community to this and have any input into it. It violated protections of disabled people to dignity, independence, and adequate fulfilment of needs under human rights, agreements, and laws. It effectively allowed for decisions about our needs to be made without us and contradicts requirements of services to take all possible actions to avoid disruption. And don't get me wrong, there were some individuals and some pockets around the country, particularly with Māori, really trying to take in the perspectives of tangata pai kaha Māori, but there was no national coordinated strategy and there was no funding to do this properly. So this last resort action was agreed by the Ministry of Health and Disability providers without working with communities first on planning and co-developing mitigation strategies. They had disabled people in tangata pai kaha Māori within their own COVID response teams that could have been involved in this, but weren't given an opportunity. There was inadequate communication about the issue, including a lack of communication to ensure tangata whaikaha were aware of their rights in this context. We trusted the system to genuinely provide for the best interests of the groups most at risk during the pandemic, and the system failed us. So what did we do? I know that our rōpū and others urgently sent communications. I know that we went to at least 3 of the DHBs, and others around the country were doing the same. I know that our rōpū sent a letter to the board of Capital Coast Hutt Valley District Health Board. We sent a letter to DSS. We contacted them directly, and to Dr. Ashley Bloomfield. We lobbied prime ministers. We lobbied the Prime Minister. We lobbied MPs, the Disability Rights Commissioner and the Health and Disability Commissioner. This was a really urgent situation. We had immediate and very good response from the board of Capital Coast Hutt Valley DHB. They were not aware of this. I had no response from my local MP, unfortunately, but the Disability Rights Commissioner was heavily committed to this, and the Health and Disability Commissioner were very supportive, and later an Omicron inquiry was launched. Sadly, within the DHB, and as co-chair of the Tangata Whaikaha Māori Disability Advisory Group, who advises the DHB, the board had supported us and instructed management to work with us and to do something about this. Sadly, management did not. In attempts bringing this to management, our voices were blocked. We were excluded from other advisory groups, and the CE and senior management referred to us as being mean when we said that our mana was being trampled on and we weren't being listened to. DSS issued an apology for the deep distress caused to disabled people and their whānau. However, this letter was sent to providers and, to my knowledge, not disseminated to the community. High levels of anxiety were there. The damage had been done for many tangata whaikaha Māori and the wider disability communities. And the high levels of anxiety were really justified. We're talking about what they medically call high and complex needs, disabled people. These are people who can't get out of bed in the morning. They can't sit up, they can't go to the wharepaku, they can't have a drink, and they can't eat. They totally rely on people turning up like they're supposed to turn up. And this is a struggle anyway. Before the pandemic came, there are real issues, and we constantly get calls from community people saying, no one's come to get me out of bed. And they call on their elderly grandparents to come and try and get them out of bed. And they call on their disabled whānau to help them. And that's who's delivering a lot of this care. It raised serious concerns for us about the ability of government agencies to plan for the impacts of emergencies in a way that ensures the rights of disabled people and whānau are upheld. And now I want to move on to a good news story. Out of this came, I guess, a relationship with our Māori director, Arawhetu Gray, who was at the DHB, the sub-regional DHB at the time. She recognised the racism and she said, you don't have to put up with that any longer. Do not engage with that. Come directly to me. It was really heartening to hear that. She gave some funding for some community research. And and I also recognised the Wairarapa DHB in this, and there's a report that they've put out here, they've asked me to provide for you. And it's called Less Talking, More Action, the views and experiences of tangata Paekaha Māori in the Wairarapa. And I speak on behalf of Whaia Marama Tuta and Whaia Boshe McGregor, who led this piece of work. He said it gave them an opportunity to hear voices of those most impacted directly. The project was run and designed by tangata Paekaha Māori within their own community. First one they've ever done. They weren't researchers, they were tangata Paekaha Māori. We supported them. They did interviews with tangata Paekaha Māori, whānau and Māori disability support workers. Across a wide-ranging topics, but in a nutshell, they covered what is good, what is working well with these services, what's bad, what needs improvement, and what are the views on the health sector transformation, especially for the Māori Health Authority. The type of approach to prioritising tangata Paekaha Māori voices and understanding their needs and aspirations should be standard, but it isn't. And I won't go through all of these, but I'll just mention a few because they really validate what has already been said by others. Particular dissatisfaction with the way health and disability services currently operate. So we're looking at this from a regional perspective now, particularly about the lack of information about supports, what they're entitled to, what's available, what can they ask for due to the lack of data. There's a likelihood that Māori are missing out on many of these services. We talked about the ableism and other forms of discrimination from health and disability providers. We talked about lack of cultural safety for them. These are basic things that have been fought for many decades now by many of our leaders in Māori health and in education, etc. Participants raised issues about service availability, the lack of suitably trained workforce, and no clear complaints process. You know that the voices of tangata Paekaha and often disabled people do not get asked for. We're not asked to evaluate the services. So when something goes wrong, like in that COVID Omicron response, there was no opportunity for anybody to go with it to really highlight that. Being heard is a constant struggle. Government agencies, internal changes mean hard-fought relationships can be eroded overnight. There is some really good people, really good officials and people that we've come across in our DHBs and our health system. But it depends on them personally. And when they leave, what's been put in place over many years just falls apart. The importance of engaging with tangata Paekaha Māori isn't an organisational or system value. And as I say, depends on these individuals. And you start all over again if you have the energy and if you're still alive. Our identities and ideas are not seen as legitimate or valued. We work around systems or hierarchies because that's an essential. You just have to do it. You have to get around the barriers that they keep putting there. Even as trained health professionals, the system blocks our voices when seeking things like emergency care. This is happening right now, and I was witness to this just recently. And there are many, many examples of this going on in our emergency departments right now across the country. There's lip service to the importance of disability in tangata Paekaha Māori, not translated into meaningful engagement on policy design or implementation. There's lack of tangata Paekaha Māori in decision-making roles, both for Māori and non-Māori organisations. And our participants said the solution is to re-indigenise the health and disability system, not just to decolonise it, but to re-indigenise it, only because Pākehā, or the white man, has had all these years, 150 plus years of doing it their way, and it hasn't worked for our people. So solutions, national recommendations are we need a whole water system, and we've heard others say this. We are not just tinana. We are not just our body. We have holistic aspects that all need to be addressed. We need this national dialogue. We need to determine our own kawa and expressions of tikanga Māori, led by us. Rangatiratanga and partnership and action, including changes to requirements for tangata whai kaha Māori in board positions, and investment in skills and professional development. Investment in data and information that meets tangata whai kaha Māori priorities, and investment in tangata whai kaha Māori research capabilities across the research pipeline. Further recommendations from the Wairarapa report gave direction that reinforcing these solutions. Many of these things are coming out in different ways across the whole of the motu. They want to see whaikaha working with other ministries, such as the Ministry Whaikaha, the Ministry of Disabled People, Ministry of Health and Health New Zealand, to embed holistic approaches to hauora and wellbeing, invest in using Māori models of health, cultural safety training of providers, and health and disability professionals. We need mechanisms to ensure tangata whai kaha Māori communities have a say in policy design and also in the monitoring. Currently, well, from the old system, DHBs did give out some contracts to primary health care. When we asked them how they monitored that, they said they didn't. We asked them to set up some monitoring, some accountability, because we said we are not getting the supports that we need. They said they couldn't do it. Invest in kaupapa Māori services by Māori providers and Māori communities. Need to build the tangata whai kaha Māori workforce and ensure kaupapa Māori options are within all disability services. I don't have access to kaupapa Māori services. I live in one of the largest, if not the largest, suburb in Aotearoa, New Zealand. I do not have access to kaupapa Māori services. I don't have access to whānau ora services. And when I contacted a Māori health provider in the region and wanted to work with them, and they work very hard, I can tell you that, they're amazing. And I asked them, how many tangata whai kaha Māori do you have? She said, we have no way of knowing. We don't know what their disabilities are. She said, we don't even know how to assess them. We don't have anyone training us in that. She said, could you come here and train us in what disability services are available and how we assess it? And I said, well, I'm a researcher. I don't know, it's not really my role, but this is what they need. Māori providers are very willing, but they need to be funded and they need to be trained. And our nurses need to be trained in disability training. We didn't get any. Our doctors need to be trained. And finally, I'd just like to share with you some draft findings, well, almost finalised findings, that have come out of our qualitative research project. We were hoping to have these published by now, but we've just finished revising. They've been reviewed and we've just finished revising them. This article is called Ka Rangarua, Ka Rangamaha, Māori with lived experience of disability self-determining their own identities. Ka Rangarua, the rua is obviously two callings, Ka Rangamaha is multiple callings. And Whaia Linda Waimari Nikora has led us in this kōrero to help us develop this with our tangata whai kaha Māori participants, because she says You don't have to choose one identity. You don't have to say you're disabled. You don't have to just say that you're Māori. Depends on your context. You identify yourself, and we all do this. I identify to iwi. That's perfectly acceptable. So it's perfectly acceptable for tangata whaikaha Māori to have multiple identities. This article talks about and highlights the voices of Māori with lived experience of disability. It highlights the impacts of colonial health and disability systems that have failed to both honour te tiriti o Waitangi and remove or address ableist policies, environments and attitudes. Māori ways of being and identifying, of knowing and doing are critical to advancing the understanding of the impacts of disability, to address the priorities and aspirations of Māori with lived experience of disability for their whānau and their communities. We kororo about the challenges and the moe moe, our vision, and our participants talk about their journey